I'm really happy to be here today. As Peter mentioned, I'm a SSHRC postdoctoral fellow in the School of Political Studies. My work focuses on disability policy, but social inclusion has really been a guiding focus of my doctoral work and the work that I've been carrying over into my postdoc. So the work that I'm presenting today is on barriers to inclusive housing for people labeled with intellectual and developmental disabilities in Canada. This has been the subject of my postdoc, but the specific focus on barriers is something that I want to take up with a sort of broader view today. And so, before I jump into the agenda for the talk, I want to first kind of talk about what I mean by people with intellectual and developmental disabilities. In the broadest sense, this refers to a group of impairments that are acquired at birth or early in life that affect one's ability to learn. And there's a broad umbrella of diagnoses kind of included within this term, and that includes autism and Down syndrome, different diagnoses of impairment. But when people in the disability community talk about disability, often we're referring to in interaction with barriers. So not on the impairment itself, but rather on disabling barriers which occur external to impairment, external to an individual. This is in line with what's called the social model of disability. And so for people subscribing to this theoretical tradition, disablement occurs through interaction with barriers. Barriers can be environmental. They can be spaces that are inaccessible. So if you are in a power chair and a building does not have a ramp for you to get in, that's an inaccessible space. There's a barrier to your inclusion in that space. But barriers can also be social. They can be rooted in attitudes, discriminatory attitudes. Say, an employer who has a preconceived notion about what an impairment might mean for a person and decides not to hire them, that would be an attitudinal barrier. And these types of barriers are often the most pervasive and difficult to overcome for people with intellectual and developmental disabilities. And so the role of disability policy, in contrast to these barriers, is to provide accommodations, to provide mechanisms to overcome these barriers, and really to promote inclusion, right? The idea of inclusion and disability are very tightly interwoven in the theoretical sense, but also specifically in the types of policy interventions targeted at this population. And so when we talk about those policy interventions, the starting point always has to be the first policy intervention that was directed at this group, which is the residential institution. So the history of residential institutions is a history that is as long as Canada's history. The first asylums existed in this country even prior to Confederation. But the first residential institution was set up in Orillia, Ontario, the Huronia Regional Centre, which opened in 1876. These places were and are human warehouses, right? Sites of really terrible atrocities. People who lived in these places were separated from society, housed in large congregate facilities, many to a room, subject to really abhorrent conditions, malnutrition, over-medication, abuse, forced sterilization. It's a really dark part of Canada's history, and it's a part that is still occurring. So while Huronia Regional Centre shut down in 2009 and Ontario has pretty much fully deinstitutionalized, there are still residential institutions operational in most Canadian provinces. I think some people are really surprised to hear that when you think about some of the things that are associated with these places. As part of this work, I went to one. I visited a residential institution in Nova Scotia, spent 2 days there touring the facility, talking to staff, doing focus groups with the residents, talking to management, eating the food. What I observed there was very much in line with this model, right? It's still very much consistent with this model of housing, which was scary to visit with my own eyes. And so I guess the bigger question that sort of animates this talk and my research on housing policy more broadly is why does the institutionalization of people labeled with intellectual and developmental disabilities still occur in Canada? And so when I talk about barriers today, that's kind of the question that's in the back of my mind, right? Not only why do residential institutions still exist in most Canadian provinces, but why are policy solutions that are very much in the tradition of institutionalization still favored by governments throughout this country? And so the agenda is first we're going to look at political barriers. I'm a political scientist. The way that we kind of and specifically a policy scholar. So we're kind of obsessed with the relationship between politics and policy. And so the way that I sort of envision that relationship is politics provides a background into which policy is injected. And so first I want to kind of set the stage by looking at some of the political barriers in housing for people with intellectual and developmental disabilities. And so specifically, I'm going to focus on the concept of systemic ableism. So how discrimination against people with disabilities is really woven into the political institutions of this country. And I'm going to talk about that by drawing upon work that I did with a colleague at Carleton University, Megan Linton, who is a PhD candidate in sociology there and is a really brilliant scholar and activist and podcaster and wears many incredible hats. So that'll be the first part of this conversation. In the second half, I want to talk about some of the more specific policy barriers and get to the question of why housing for people with intellectual and developmental disabilities is marginalized on the social policy agenda more broadly. And I think this is a real important contributor to why this institutionalization still occurs, is because, housing solutions for this population remain sort of marginal within the broader conversation of housing in Canada. And we'll conclude with a short discussion of what can be done, and hopefully that will segue us into a fruitful question and answer period where we can maybe draw on some of the experiences of the people watching today, who I'm sure also have relevant experiences with this population. Okay, so beginning with systemic ableism. So as I mentioned, I'm in Montreal currently. I live in Quebec, and in my province, there's a large discussion about systemic racism, right? The premier of Quebec is really hesitant to acknowledge the systemic racism is an issue or is even part of the political context here at all. I think there's a hesitancy to acknowledge sort of the pervasiveness of discourses of discrimination and how they're sort of interwoven into the politics of different jurisdictions. And so that's the kind of argument that I'm trying to make today. I'm trying to say that ableism is a form of discrimination that's really woven into the political fabric of Canada as a state. And so I want to sort of unpack what I mean by that. So to begin with, we have to wrestle with what is ableism, right? It's not maybe as common of a discussion of discrimination for some, but ableism refers to prejudices against or about people who are presumed to be or are disabled, right? And so it gets to those social or attitudinal barriers that I talked about earlier. It has to do with the perception of disability and assumptions about disability, but is often manifested in stigmatizing or discriminatory attitudes about disability. And it draws from casting disability against a non-disabled norm, right? So if you kind of break down the performative expectations for citizenship in Canada, what we expect of a person to be sort of an autonomous and independent person within our society, we have really strict sort of performative expectations of what that looks like. And so ableism often manifests in ideas which are positioned against that non-disabled norm and are casting difference relative to that non-disabled norm. And so systemic ableism occurs when that normativity is woven into the fabric of a political institution, when those ideas become part of how a policy problem, for example, is defined, and thus the universe of solutions available to solving that problem. And so what I'm specifically referring to here is the idea of a policy legacy. This is a concept from the study of public policy. It's rooted in a tradition of historical institutionalism. And the idea is that the way a policy is defined at its outset shapes the universe of solutions that are available to solve that problem. And then once you actually create a sort of policy, you design a policy to solve that problem, the ideas that were present at the generation of that problem definition become interwoven into the policy itself. And then once that policy is enacted, it becomes resistant to change. And so those ideas themselves are resistant to change. They're resistant to contestation over time. And thus feedback effects create a sort of path dependency, create an institutional character to a policy as it is enacted over and over time. Now, this is maybe an idea that is tangible, right? It makes sense. We certainly can I can understand how the Canadian state has certain characteristics vis-a-vis its interaction with certain populations, but it does become difficult to observe, right? How can we tangibly identify and analyze policy legacies over time when they're supposed to be manifested in ideas? Like, how do we observe these ideas? And it is a problem for the study of public policy. And it's a reason that it's difficult to engage empirically with the idea of a policy legacy. What we did in this work was we borrowed a concept from sociology called haunting. And this is about accounting for that which is not there, right? It's often used in indigenous politics to contend with settler colonialism and how that idea manifests itself over and over in relationships between the Canadian state and indigenous groups. The idea is that these logics from the past haunt contemporary policies. And so by unpacking these sort of spectral logics, these ghosts of the past, which may not be consistent with the language or discourse of policy in the present, but still affect the outcomes of policy in the present, by unpacking those ghosts and giving shape to them, we can see how these logics act over and over to kind of limit the potential of transformative change within a policy area. So the method for this section involves interviews. As I mentioned, I did some work at a residential institution. I spoke to personal support workers in 2 provinces for this work. Also spoke to people with intellectual and developmental disabilities, policy advocates, civil servants. So I tried to speak to people throughout the implementation of developmental services policy to get an idea of how it's enacted in the present. And so we propose that there are sort of 3 spectral logics. So when we talk about how haunting occurs and how this policy legacy of systemic ableism is enacted over and over in the present, we identify 3 spectral logics. So the first is the idea of exclusion. Right. So this is when you think back to the establishment of the residential institution, this was a really formative idea that people labeled with intellectual and developmental disabilities should be excluded from the rest of society. And it's based upon the ableist assumption that intellectual and developmental disabilities are a pathology, are a sickness, something bad that happens to someone that needs treatment, that must be isolated, contained, and treated. So it's very much in the auspices of the medical model of disability, right? Seeing disability as a medical problem. So it's foundational to the establishment of institutions, as I mentioned, that they were set up in residential areas. Often, if you want to look at where institutions are set up, they're usually 2 or 3 hours north or east of a city, right? So the idea is you take people out of the city, move them to somewhere where they're isolated, then there's a potential for rehabilitation and reintegration, but mostly they would just languish in these places, hidden away from the rest of society. So we wanted to look at how this idea of exclusion is manifested in the present. And the way that we did was by looking at how these institutional characteristics are preserved in the housing model that has come to replace institutions. So while residential institutions still exist in most Canadian provinces, the dominant model of housing support now for people labeled with intellectual and developmental disabilities is the group home model. This is as a result of the advocacy of the community living movement, which started in the 1960s and 70s and pushed for housing options that would integrate people with disabilities into the community. So group homes were set up to be housing for 3 to 8 individuals in a standalone house with support staff on hand to provide relevant supports. From the very outset, they were met with pushback by communities who didn't want group homes on their street. The idea of NIMBY, not in my backyard, was very much part of the discourse around group homes being set up. But they were proposed as a viable alternative to institutions because of their potential to provide socially inclusive, person-centered care, right? By putting people in a community, you're de facto giving them a chance at inclusion. The problem with group homes since, though, has been that there's too many and never enough. So too many in the sense that group homes have not really managed to escape some of the characteristics of the institution. So they're still isolative places. They haven't been able to promote the kind of community engagement that they were designed to provide. But never enough, because there has not been enough group homes developed to deal with the supply of people labeled with intellectual and developmental disabilities who require supported housing options. And so we have wait lists in across the country. In Ontario, the wait list is at least 15,000. That's an approximate number that's a couple years old at this point. We know that it's actually quite a bit more. And so there's never enough. So how are they haunted? Well, one, as I mentioned, there was this a NIMBY backlash to group homes from their very outset. So in the zoning requirements for the development of group homes, they're limited in terms of how many can be built within a particular geographic space. And that was designed to mitigate sort of negative impacts on communities. What's more, the model itself continues to impose limitations on resident autonomy. So within the practice of group home supports, you have surveillance. Often the doors are locked. There's limitations on who can leave and come and go, visitation. You don't have choice over who you live with. So there are all these ways that autonomy continues to be limited. There's also the imposition of restraints, both physical and pharmaceutical restraints on people living in these spaces. So their autonomy is limited. And there's an additional problem of the lack of oversight, right? So because this model of housing exists on a smaller scale, there's not the same type of accountability and oversight that you would have in a larger scale residence. The second ghost that we identify, the second spectral logic that undergirds systemic ableism, is the ghost of elimination. And so this is a much more pernicious form of ableism that arose at the beginning of the 20th century and involved the devaluation of disabled lives, right? The ableist rationale of disability as a sickness was perverted into the idea of a moral panic around the genetics of disability as something to be weeded out from society. And this was most pronounced in the eugenics movement at the beginning of the 20th century. This gave credibility to the pathologization of intellectual and developmental disability. So it not only took this foundation of disability as a sickness, but actually brought into effect mechanisms to try and curtail the impact of disability on society. Most notable example is Alberta's Sexual Sterilization Act. This is a heavy topic to talk about. So I'm sorry for not providing a trigger warning because, it is a heavy topic. But this act governed the sterilization of people in residential institutions, and the determination of who would be subjected to forced sterilization was based on scores on IQ tests and was related to false assumptions about the heritability of intellectual and developmental disabilities. And so while forced sterilization doesn't occur anymore, thankfully, there are contemporary manifestations of this sort of panic about the propagation of disability, and some of them can be tied back to those sort of false assumptions about heritability. So one is through soft forms of population control within group homes. So limitations on who can come and go and the surveillance within group homes really prevent the potential for sexuality among people living in group homes, right? There's not the same opportunities for education on sexuality, let alone the opportunities to actually experience that. And so there are limitations there. There's also the expansion of medical assistance in dying to people with intellectual and developmental disabilities, which again is legible within this sort of history of elimination. People with disabilities are the only group for whom medical assistance in dying is expanded without the imminent risk of death. So when they're not actually facing death. This has been something that advocacy groups have fought vehemently against because of what it's basically saying, right? Which is in the context of a society which doesn't provide adequate supports to people labeled with intellectual and developmental disabilities, the offering of medical assistance in death is saying we would rather you die than provide the supports that are required. And that's the discourse that these advocacy groups are fighting against, and they have evidence to support their claims. In 2021, 4.3% of MAID recipients reported unmet needs from disability supports. And these discourses are ubiquitous in the news. You see people saying this is an alternative that I'm being forced to consider because the supports that I need to live are not being provided to me. Okay, so that's how elimination manifests in the present. The third and final sort of spectral logic that we look at in the paper is the ghost of extraction. And here we focus on how the politics of austerity tries to generate profit from disabled bodies, or at least mitigate costs in the provision of supports to disabled bodies. And specifically, what we focus on is the reinstitutionalization of people with intellectual and developmental disabilities. So when I started doing this work, deinstitutionalization was an accepted fact, and social inclusion was a normatively accepted fact, right? Like you would never think of having a political discourse that was explicitly exclusionary. This is maybe 6, 7 years ago. Things have changed a lot, though, right? You know, if you look at how the nature of political discourse and how it's changed over time, narratives of exclusion are increasingly woven into our political discourse. Again, I'll bring up an example of living in Quebec. You know, there are explicitly exclusionary aspects of this province's policies towards immigration, and those are popular political talking points. Like that is something that is a viable strategy for politicians to get elected now. And so this language of exclusion has become increasingly popular. And anyways, institutionalization also has become popular again within the policy discourse. So this was shocking 6, 7 years ago, the idea of reinstitutionalizing people, but we're seeing it more and more through policies of long-term care. I'll get there in a second. I'll start first with how extraction first reared its head. So in the residential institutions, there was this idea that even though people labeled with intellectual and developmental disabilities were pathologized, were incapable of social functioning, they could still be a source of value for governments. There was exploitive labor practices such as sheltered workshops where people were forced to engage in manual labor for 8 to 10 hours a day for a really menial wage. And this was one of the ways that the institutions would generate the profit to sustain themselves. Sheltered workshops continued and again still continue to this day across the country. Some provinces have legislation that tries to curtail working for less than minimum wage, but there are still sheltered workshops operational across the country under the auspices of day program and vocational programming. So we identify a contemporary manifestation of extraction through the inappropriate placement of people with intellectual and developmental disabilities into long-term care. So taking people out of disability services and putting them into aging services because there are places there, because there are cheap beds available there. This is one of the strategies that governments have begun to use to deal with the growing waiting lists for group home placement. An example of this is the More Beds, Better Care Act in Ontario, which has really specific guidelines for placing people with alternative levels of care into long-term care when they're coming out of hospitals. And why it's beneficial to governments and why it's extractive is because providing care to people in long-term care is much less expensive than providing care in a group home. The staffing ratios are different. The cost per person, regardless of staffing, is lower, right? Because it's an economy of scale in the provision of care. And then also it moves care from one silo, from the disability services silo to the aging services silo, where there's comparatively more money. These are three manifestations of systemic ableism in the present. Why we look at these is because it gives us a way of looking at a policy legacy that's actually tangible and traceable to the discourse of Canadian disability politics in the present. And this is noteworthy because the political discourse around disability, especially for the past 25 years, has been very much consumed with this idea of social inclusion. Every significant disability policy over the past 25 years, which I call the inclusion era, has really tightly intertwined these concepts of inclusion and disability. And so it's surprising, perhaps, that we have these explicitly exclusionary practices. One of the reasons why exclusionary practices persist is because the policy commitments that have come out in the inclusion era have been non-performative. So they're rhetorical commitments to the provision of inclusion without sort of accountability mechanisms or real sort of teeth to enable the articulation of standards that would actually promote inclusion in tangible ways for people with disabilities. And this amounts to what disability scholar Mitchell calls inclusionism. It's a type of creaming where the people who are the easiest to include benefit the most from policy interventions, and the people who require the most extensive supports are marginalized the furthest. This is most obvious in some of the pilot projects and sort of some of the more exciting housing projects that have been undertaken in the past 25 years, intentional communities, things of that sort. There are exciting, inclusive models of housing, but they're often provided to the people that are the easiest to accommodate, the people with the lowest level of support needs. And they occur at the same time as these ballooning wait lists for people at the far margins who are receiving nothing and who are languishing in a total absence of services. And so by naming these logics of systemic ableism, we gain a level of specification, right? We move just beyond saying the system is itself ableist and this sort of monolithic character of that characterization. It gives something more tangible to advocates and frontline workers who wish to push against those logics. And it allows us to move past the non-performative discourse and see Canada as this haunted house, right? As this country whose political institutions are still haunted by these ideas from the very outset of disability policy. And so that provides kind of a good opportunity to engage now with some of the policy barriers. But before I do, I just want to give a quick plug to Megan, Megan Linton, the co-author on this section of the presentation, her podcast, Invisible Institutions, which is a really incredible resource for folks who are interested in learning more about this history and how it's manifested over time. All right, so now we're going to move on to policy barriers. Again, I'm going to take sort of a broad view. I'm happy to go a greater level of specification if people are interested in the Q&A, but there's sort of three types of policy barriers that limit the potential for inclusive housing policy for people with IDD in Canada. The first relates to governance. So people labeled with IDD are marginalized within the provision of social services, and part of this has to do with the governance of social services. There are numerous coordination dilemmas that exist throughout how these services are provided, and I'll go into detail about those. Second relates to spending. Of course, health and social services in this country are mired by politics of austerity, and this really limits the potential for truly inclusive housing options. And then the last is staffing. It's a very precarious work environment for people providing supports in the housing arena to people labeled with intellectual and developmental disabilities. And of course, this has been amplified by COVID-19. And so I'll go through each of these in turn. So starting with governance, because so many actors and organizations are involved in the provision of developmental services, we have dilemmas throughout the implementation chain. One, we have dilemmas between siloized social services. So as I mentioned earlier, there's a silo of aging services, the silo of disability support services, the silo of social housing, right? All of these exist within different governance architectures and don't communicate seamlessly with one another. So that creates dilemmas of coordination. When you think about developmental services, here's a really simplified model of how it exists. It's provincial purview, right? In Ontario, for example, you have the Ministry of Children, Community and Social Services, which is at the top of the governance chain. Below them, you'll have a regional service center who coordinates service provision among various agencies. Then below them, you'll have the agencies that provide the services themselves, who could provide residential services, day program services, vocational services. And then below, working within these agencies, you have the workers, the managers, the people who are actually tasked with implementing these services with people, right? Even within this really simplified model of developmental services, you can see that there's room for coordination dilemmas among the levels. But then you also have dilemmas between specialized service agencies. So when you have one agency providing housing supports and one agency providing vocational supports or day program supports, their ability to communicate with each other can be problematic. There's also problems between public and private providers. You know, within developmental services, it's mostly public provision, but as we start getting into long-term care, we have private providers. As we move across those service silos, there's disagreement between public and private providers on certain modes of practice. And then there's also disengagement with agency staff or temporary staff who provide supports within even public silos. So we have, even within developmental services, which is a public provision overseen by the province, there are agency staff working for-profit agencies providing some of the care who are contracted in where there are not personal support workers to provide care. And then, of course, there's coordination dilemmas between levels of government. So I provided a simplified model of developmental services. Here's a more complex model of what it would look like in the city of Montreal, right? So you have three levels of government. Government of Canada, who has an impact on housing policy through broad policy acts, also through community housing benefit. There are policy interventions at the federal level with an impact over housing. Similarly, within the government of Quebec's purview, you have the Department of Housing, which has some impact on social housing services, which can be taken up by people with intellectual and developmental disabilities. And then you also have the Ministry of Health and Social Services with purview over its own set of housing supports. And then the city of Montreal also has its own basket of services to provide supports to people requiring assistance with housing. When talking about how the governments relate in political science, for a long time, we talked about a vertical imbalance, how the federal government has been passing down responsibility to provincial governments. But lately, what we've seen is local and municipal governments really picking up the slack for provincial governments. So, for example, in light of the wait list that we talked about, cities have begun to try and deal with the problem of people who require supports by coming up with their own forms of congregate care without the same types of accountability mechanisms, without the same types of professionalized staff, with a sort of institutional character, but out of necessity because there's just nothing else provided by the provinces. And so the outcome of all of these coordination dilemmas are service gaps, right? Where these different organizations and agencies are unable to communicate with each other, there are gaps in services. This is how things like the inappropriate placement of people in long-term care, the creation of de facto institutions at the municipal level, all of these less desirable outcomes occur because there are gaps in services which come from ineffective coordination between these different organizations. The second kind of group of policy barriers relates to spending. I mean, the politics of austerity in health and social services have been going on for a very, very long time, but have really ramped up over the past 15 years since the recession of 2008. For governments, deinstitutionalization is expensive. For the provinces that still have residential institutions active, that's been a product of the fact that it's extremely expensive to create and transition to group homes. When I was in Nova Scotia speaking to people there who have been pushing for a transition towards deinstitutionalization for over 50 years, the barrier is that they're unable to afford to set up group homes in communities, to buy the residential area, and then also to facilitate appropriate transitions. So it's expensive not only to create group homes, but also to facilitate a thoughtful transition for someone who's been living in an institution their whole life. You want to make sure that that transition is as seamless as possible. Who they live with, where they live, who their staff is there access to staff where they're going to be? All of these questions become part of the solution. This has been compounded by the housing crisis, right? Especially in cities, the cost of the types of houses that would be turned into group homes has skyrocketed. In cities like Vancouver and Toronto, it's an extremely expensive proposition. And once again, this is pushing people towards congregate housing. A lot of the new builds for providing supports to people with intellectual and developmental disabilities are based on a congregate model of provision. Because this builds on an economy of scale, right? As I mentioned earlier, it draws from other service silos. So where people are placed into long-term care, it's within the silo of aging services. The other benefit, of course, is staffing ratio. So in a group home, typical staffing ratio would be 1 worker to 3 residents. Whereas in long-term care, you're looking at a staffing ratio of, at the very best, 1 to 7, but more often 10 plus residents to 1 staff. And so this report recently came out in Ontario. It's an Auditor General's report. It shows that there is this steady increase in the number of autistic residents in long-term care homes. It's a pretty small number, but it is illustrative of the trend. It also could have to do with increased diagnosis as well. Autism is something that's being increasingly diagnosed in older residents. A lot of people were given schizophrenia diagnoses or mental health diagnosis that later were found to be on the autism spectrum. But anyways, the point is that there's evidence that the number of people with intellectual and developmental disabilities living in long-term care homes is increasing. And this is problematic because the types of strategies that are used in these spaces to provide support are in and of themselves extremely problematic. The use of pharmaceutical restraints is something that we have evidence from this Auditor General's report has been increasing over the past 5 years, even without a psychosis diagnosis. So the use of antipsychotic medication. Within the report itself, they talk about the more sort of embedded reporting that they've done in these long-term care homes and seen people sleeping all day just because of the weight of medication that they've been administered. This is a problem not just in long-term care, but in group homes where people following the institutional model are given extreme amounts of Seroquel and other antipsychotic medication, which has real impact on their capacity well, just on their energy and ability to engage outside of the group home. And so in my work, what I've done is create a policy index that kind of looks at differences provincially in terms of housing policy. There's 3 indicators in the index that I'll share with you. First is developmental services expenditure per capita. So which provinces are spending the most. Manitoba is actually the highest spending province on the list. And that is because they are the province that's most seriously committed to deinstitutionalization right now of the provinces that has institutions active. And so they've been spending money on group homes. They've been developing infrastructure, and that has really driven up their developmental services expenditure. I also have a small indicator, only worth 10% of the final score, on whether or not provinces actually publish their waitlist data. Most provinces do not. It's not a savvy political move for provinces to publish their waitlist data, and so most don't. The only province that provides really detailed reporting on the size of their waitlist is Quebec. Other provinces sort of reluctantly have reported through freedom of information requests and things of the like. And then still others don't give any indication to the size of waitlists. And so eventually, as I keep building this index, I would like to have an indicator that measures the size of waitlists themselves. But just for scale, Quebec's waitlist is about 12,000 people. Ontario, they reported 15, but I'm sure it's much closer to 20,000 people waiting for residential placement. And then the last indicator is just a binary indicator of whether or not they still have residential institutions active. And so the bottom 6 provinces on the total score are all provinces that still have residential institutions. Nova Scotia is one that has many institutions active, but they're actually working with a renewed sense of urgency to deinstitutionalize. And so happy to go into any of the details on this index after people are interested. Okay, the second policy barrier relates to staffing. Provincial governments have been really focused on the shortage of qualified staff. The impetus has been to increase training requirements for people getting into the field, which is a puzzling move because there has been this great resignation following COVID-19. So many people left the field after the horrors that they experienced providing care during COVID, watching people that they had provided intimate care with die and dealing with the immense strain and caregiver fatigue during that period. There were some efforts to increase wages during COVID, and that raised some eyebrows. People were like, "Oh, maybe there's finally a recognition that this is an underpaid sector, the personal support work sector. Wages are very, very low, but those were only temporary wage increases. And really the focus across the country has returned to how to increase training requirements to improve the quality of staff. And so again, from that Auditor General's report, here are the types of wages that people can expect working in long-term care facilities, for example. So you're looking at about $22 an hour if you want to enter into this field. It's not a very competitive wage when you think about the types of people that you'd want to be attracting into this work, younger people looking for a career, that's not really a viable career choice for many based on purely economic logic. And so as a result of great resignation, of the lack of people within the traditional stream of support work, direct care has been increasingly provided by contracted agency staff over time, which is problematic for a couple of reasons. First, it doesn't provide continuity of care. So as you know, with someone receiving care in a group home, receiving care in the most intimate aspects of their lives, bathing, toileting, medication, continuity of staff is really important. Having agency staff who are temporary come in and out is not a desirable outcome. Also, it's more expensive to rely on agency staff who, because they're working for-profit agencies, are able to charge much more. And so just a quick index to show how the generosity of developmental services wages across provincially. You see actually that the maritime provinces, who are very low on the housing domain, are actually higher in terms of the wages that are provided to developmental services workers. And this has to do with efforts to really retain staff within those provinces to prevent the sort of brain drain or exit to other provinces. But I can touch on that a little bit more later. So just to finish off, what can be done? This is something that I get asked a lot, and there are numerous avenues to kind of deal with these policy barriers. The first and I guess most obvious would be through conventional forms of advocacy. There are a number of advocacy groups working really hard to try and address these barriers. Some of the bigger advocacy groups work very closely with government, and for some of the more grassroots advocacy groups, they've pointed to the sort of problems of capture of these bigger groups by government. But I think it takes a village. It takes the larger advocacy groups working hand in hand with the grassroots ones. Also avoiding inclusionism, right? This idea of providing supports to the most easy to support people is really further marginalizing the people who are the most dependent on social services. And so curtailing that sort of inclusionism involves kind of a new approach. Rather than sort of working within conventional policy structures, we need to find new ways of ceding power to the types of groups and nonprofits, organizations that are working specifically with these populations. Traditional mechanisms of policy interaction between the policy makers that are actually designing policies in this area and the groups that are advocating for policy change have been tokenistic, have not involved power ceding, but rather minor forms of power sharing. And so what's required is creating new mechanisms, advisory boards, things of that like, to give grassroots nonprofit organizations with that knowledge of what's happening on the front lines, the power to shape policy design. And then on an individual level, the best thing to do is volunteer. When I teach a disability politics class, some of my students ask what can be done. The most impactful thing I think any individual person can do is volunteer, spend an hour or two a week working in a group home, see what it's like for people who are living in isolation, and see the sort of transformative potential of giving a little bit of your time to somebody who's feeling really isolated. Okay, so I'll wrap up there, leave some time for questions. I want to thank everybody for coming and for your attention.